So let me just share my screen. So today I've come to talk to you about the Reducing Long Hospital Stay programme, which I've been working with ECIST now certainly for the last year, on and off more before, but then COVID unfortunately got in the way of some of that. But I've been working with Rachel and the team in the last, is it 3-4 weeks now, Rach? Well, we've been looking at trialling something different just for you had a multi-agency discharge event or some event at the hospital, not last week, the week before. And so we were trialling something new there, just playing around with some ideas. So we can hear from Rachel in a little bit just to see how some reflections or what people thought of that. But this is where that whole process came from. So fundamentally, we want to reduce the length of stay of patients in hospitals. And many people will think, oh, it's just, here's NHS England and they're here chasing a target and we're here looking at performance. And this is absolutely not what this is. So we look at patients and we make patients at the centre of everything that we do. So this is Betty, and she was a trust of mine that I was working with at the end of last year. And Betty had some cognitive impairment and heart failure, arthritis. She was visually impaired, but she had an unsuccessful cataract operation, but she could see marginally, but again, not brilliantly. She had some renal impairment, which she was on multiple different drugs for. She was frail. She could walk 5 meters only with a frame. She had carers 4 times a day and was really beginning to be on the limit of that care package. She had a history of falls, and she'd had one period of hospital admission, and that had been 9 months previous. She was admitted in September 2023, and she had a urinary tract infection. She had mild dehydration and some postural hypertension. She spent 20 acute hospital, and then she spent 2 weeks in a nursing home. And can we imagine, or can we think what may or may not have happened to Betty? Can anyone shout out? I can't see anybody because I'm sharing my screen. So if anyone wants to shout out, what do we think happened to Betty?
Deconditioned.
Yeah. Yes. And what do you think the ultimate outcome was?
She's died.
Yes, she did die. Tragically, she did die. And she didn't die of her UTI or her mild dehydration or her postural hypertension, but you're absolutely right. It was fatal harm, and that was from deconditioning, and that was secondary to the congested hospital. So we know that hospitals, and as you've rightly said today, your hospital's running quite hot today, and we know that hospitals become really congested. And years ago, when I used to work when I used to manage Southampton A&E, I worked with Mike Clancy, who was the president at the time of the Royal College of Emergency Medicine, and he always used to say to me, Angela, do you know what he said? A&E is the stage by which everything plays out. And I never really understood what he meant, but I think what he meant, and I now know what he meant, is all of the bottlenecks that happen throughout the whole of the patient's pathway. So we have patients at home who are dialing 999 or 111 for ambulances, or for admission, or for referral into acute services. And they are waiting at home because they don't have anybody who's responding to them. And that's because invariably they're sat on the forecourt at an acute hospital. And that's because they can't offload their patients into the emergency department, because the emergency department is full. So we know that we've got too much demand coming in through the front door and not enough capacity to be able to house them. And we know that we're struggling to get patients out of the emergency department because the assessment units are also equally full, because they've got patients coming to them from GP referrals, they're coming straight from the emergency department, they may be coming from the same day emergency care unit, from the walk-in centres. So they've got a whole heap of different pathways of patients coming to them. And so they're trying to refer their patients on to specialty wards, so cardiology going to cardiology in an ideal world, and frail patients going to the care of the elderly wards in an ideal world, because we know we need to get our patients in the right place at the first time. And so we're trying to get these to try and get the poor patients out, but of course there's no demand, there's no capacity in the speciality wards. So therefore the patients are sitting in each one of those steps. And then we know that once the patients become fit for discharge, or they have no more criteria to reside in an acute hospital, that they are then still sat stagnant in an acute bed because there isn't the capacity to be able to send them out into the community for ongoing care or for reablement or therapy or any other needs that they have in the community setting. And so all of that plays back to the A&E stage, by which my esteemed colleague told me, and those poor patients at home who are undiagnosed, undifferentiated patients who are waiting for ambulances, who are critically ill that we don't know what is wrong with them, as opposed to patients who still need some care and some support but don't need to be in an acute bed. So I don't know how many of you were around and doing jobs in the hospital before COVID, but we used to, and I say we in the sense of my ECIST colleagues, look at a process called Long Stay Wednesday. I don't know if many people remember that. And this, which I've been doing with Rachel for the last couple of weeks, is exactly the same process, only slightly modernised. So rather than pulling nurses off of wards, which happens or used to happen a lot when I was working operationally, to give assurance and updates operationally to the managers and operational teams within the hospital, we have a roving ward team that goes around to each and every clinical area. Now, you can make that as narrow or as broad as you want. I've been doing this in hospitals where we've looked at specifically trauma and orthopedics. I've worked in some trusts where we've looked at just medicine or only 4 or 5 wards of medicine. And then I've worked in other trusts where we've gone completely across the whole hospital. And so listening to the nurses on the wards saying, you know, it takes so much time of our day to keep coming off of the wards away from our patients into these admin areas. We took a roving team to that ward. So it was a senior manager or a manager of the discharge team, a member of the discharge team who is familiar with the ward. Now, some wards will have discharge coordinators who are absolutely all over the detail. A senior therapist, now that can be either an OT or a physio. Now, the expectation is that they probably don't need both. I mean, because of constraints on resource, but the expectation is that they will take escalations for each other. A senior therapist, a matron, so for that specific ward area. And there should be a rota that will cover it in case matron's off on holiday or off sick, then one of the other matrons will pick it up. And then most importantly, actually, in all of this is the administrator. And ideally, somebody from an operational background or somebody who will understand the running of the hospital and some of the languages that we use around patient delays or acute patient stays. And all of this process of going to the wards is based around 4 very simple questions. Does this patient need to be in an acute bed? And that's a very simple yes or no answer. What is it that they are waiting for? So, and again, I will show you in a minute with the dashboard. And what needs to happen next, and by who and by when. So those are our actions, by who's doing what or any escalations. And then what code is based on the national SITREP codes, which have just been updated, which I think you use. Is it Nerve Centre, Rach, that you use?
That's right.
Yeah, so nerve centres, and they're absolutely, they're exactly the same as the ones on your nerve centre. So it won't be any surprise when you're marking your no criteria to reside and your delays on nerve centre. So you will go round to the wards, and you'll go to the wards in exactly the same order at exactly the same time, and where it's worked best is when it's been happening twice a week, and that's on a Tuesday and on a Thursday. So by doing it on a Tuesday, you're picking up any problems or any constraints that have happened over the weekend. And then by doing it again on a Thursday, you're looking at any problems that are going to be happening going into the following weekend. And then if you can have the same team working on a Tuesday and a Thursday, you will have continuity. So I've been on some reviews where we've expected a patient to go home on Tuesday. We've come back 2 days later to find the patient still there, but you still have that organisational memory of, oh, hang on a moment, what happened? Why didn't she go? What needs to happen? And the whole process becomes very fluid. What we've said to the staff is, if you're doing any other safer meetings or red to green meetings, if you're engaging in this process here with the 4 questions, you will be stepped down from those other meetings. So we're not here to duplicate work that's happening. This will be instead of. So, and by having this structure, these are the 4 questions that will be asked. So again, I've started off in other places with the 4 questions, and I've gone back to review a month later, and they've multiplied to 14 questions. Yes, all of those questions are important, but they're not needed for right here and right now, because this is very much a snapshot of what's happening and what needs to be done and what are the actions. So the administrator will input the data into a spreadsheet, which I've designed, and the spreadsheet is here, and this is just a snip, so it doesn't show it, but these will work on drop-down boxes, and the delay reasons, you click on it and it will give you all of the codes, so you can categorize what the delay reasons are, or whether they do or don't need to be in an acute bed. And then there's free text there, so you can say, okay, so we're waiting for antibiotics, or we're waiting for discharge, or we're waiting for something else, or we're waiting for, blood results to get to this, or HB to become this, or we're waiting for the family to come in. And then the action would be, so I'm waiting for Jyoti's going to review with the family on Tuesday, and she's going to come back and let us know, or we've got pharmacists coming to the ward at 5 o'clock, and then we'll book trauma. So that's where you put your actions and your next steps. And then this worksheet will be filled in by the administrator, but will usually be held by either somebody in the ops team, so you know what your delays are. But at the same time, there's 2 tabs to the dashboard. There's the first one that we fill in, and then that pulls through a report, and it will automatically update as you're filling it in. And it works on a Pareto analysis, which is a fancy word for a tally chart. And so it will work out what your top 3 or however many delays are in order of popularity, shall we say, of your delays. And so we would expect every person on every ward, a member of staff, to know what their top 3 delays are in their clinical area. And then this report can be printed out. It can be put on your or your staff board to say, this know how we're doing in the staff room, this is how we're doing, and these are our top constraints this week. Or we've got, I don't want to pick on pharmacy, but we've got a problem with pharmacy, or therapists aren't responding, or we've got delays with diagnostics, we've had a scanner break at the weekend. And so some of them will be long-term issues, some of them will be short-term issues, but you can feed this into your ward areas and your governance meetings, so your divisional meetings or your care group meetings, to start looking at your short, medium and long term. And then what this did is I started doing it at Torbay, and when we started off, it went down, and then we had a little bit of jiggery pokery where I think we had somebody leave, and then they had some wards closed with COVID, and we really had to sort out okay guys, this is happening every Tuesday and every Thursday. It starts at 10 o'clock in the morning, and we were on a bad day finished at 12. So we could review 30 to 40 patients in 2 hours, and that was going across 5 or 6 wards, because we added in an extra ward, and as the numbers went down, we managed to reduce the length of stay that we were looking at. So people started by saying, oh, you know, this bit here, we can't commit to this every week. This is really arduous. We're really struggling. But arguably, the impact that this had on the length of stay across the acute hospitals, and that was for 7, 14 and 21 days, and then the increase in the 4-hour performance, so the increase in patient quality of care in our emergency department, and then we've got this sweet spot here in the green where the time in the emergency department is reduced as the number of length of stay is equally reduced. Is really important. Actually, we said to people, do you know what, this is probably 10% of your working week that we're asking you to commit to this, and it's having such a huge impact. So we thought, okay, so we started it in the acute trust, and then we started to look at it in different places. So we looked at it in the Torbay community. So I've also got exactly the same dashboard, but I've got all of the community codes input into it as well, so that we can make it relevant for community. And it did have an impact, probably not as much as the acute trusts, but it did have more of a qualitative impact in the staff were coming knowing their patients, they had their answers to their 4 questions, they were preempting some of the solutions to some of the constraints and delays, and they were really open to challenge, because there's nothing wrong with challenge as long as it's done with professional courtesy. And then we did it for Maidstone and Tunbridge Wells. And then we also did it for Royal Cornwall as well. Now, we started with Royal Cornwall with just orthopaedics, and now they've rolled it out across their acute trusts. And I'm now just beginning to work with them as well to look at their community trusts as well. So I'm going to their nurses meeting this week to try and launch it with their community teams. So just before I pause for air, so what is really needed of this whole process is discipline and commitment. So we need the staff to commit to the weekly process. It needs to be, to begin with, it needs to be on a Tuesday and on a Thursday. And the staff need to know their patients. So we need them to come with the answers to the 4 questions of the patients by whichever length of stay group we decide. We may decide to look at just the 21 days and over, or 17 days and over, or 14 days and over, but we expect them to know the answers to those 4 questions. There does need to be senior leadership oversight at every session, and that's somebody who can help with some of the challenging questions, somebody who has a helicopter view, and somebody who can also help with some of the escalations. Medical staff engagement is absolutely paramount in all of this, because we all know, and I say this as a nurse, I cannot make discharge decisions. I can make decisions around how to discharge a patient, and I can follow criteria-led discharge, but I cannot I cannot decide that the patient needs to be discharged and when. So we need to start engaging with our medical staffing colleagues. The processes need to be parallel and not linear. So a lot of the time we hear, oh, I can't do this until, physio can't come and see until the patient's medically fit. I can't order the TTOs until, I can't book transport until. But we should be planning for discharge at the moment of admission. We look for use of internal professional standards as well. So a lot of when we started to look at this and we picked up themes, we realised that the staff on the wards don't know what they don't know. And it's okay to say, look, Mrs. Jones is, I didn't know how long it was before I could escalate. But if we have internal professional standards, we will know that, for example, 2 days is an amount of time to wait for a diagnostic. After that, this is the process and this is who we contact. And then they have a certain amount of time. And then how does that fit with our whole trust escalation policy? And what is the response time in terms of it? Some of that will change if you're in OPAL level 1 or OPAL level 4, an internal critical incident. But there does need to be a step change in terms of flexing up for escalation and then de-escalation. Need to properly understand capacity and demand, and that's by specialty as well. So do we in our bed meetings, and again, I use the wrong way, I don't know the answer to this, but do you guys know in your bed meetings what your demand is going to be on each specialty every single day, and how many discharges per specialty you know? Some places do, they would work on a rolling 6, or some places will have it built into their bed dashboards. When I was director of ops, I used to know that for respiratory, I would have roughly 4 admissions a day, therefore I'd need to make roughly 6 discharges to be able to get me through the night, and then the unexpected one emergency that we'd have. So do we have that granular level of detail? And that will then also help. But this whole process will help to really focus our mind on what discharges we've got going for that day and then for the next 24 and 48 hours. And then we just need to be thinking outside of the box. It's not making people maverick or making them make unsafe decisions or be too risky, but it is just, where does the risk sit? And if we go back to this one here and we just remember this, where does the risk sit in this? The risk sits here with the patients that are undiagnosed, sat outside the emergency department, or the patients that are sat at home waiting for an ambulance. We don't know what's going on with them. This is where the risk is sitting. So let me stop